Coming to the molecular methods, like how many of us in private practice have got call for Nipah virus in last 1 month?
In our stage, we have the Nipah virus.
Yeah, that's why I'm asking. How many of us in private practice got a call for Nipah virus?
Everybody was quite afraid.
Everyone was quite afraid.
Not to travel to carry.
Yes. How many, means at least for private hospitals, each one of us, all the microbiologists, we got a call for Nipah virus. How to take care of the travelers who are going to this part, or what test should be done. What test should be done for these patients. So I'll be talking briefly about the molecular tests which are available as of now. Okay. So again, going back to the basics, as sir has set in the pitch for Casebase, I'll be talking about two cases. The first one is 50 to 7 years in septic shock. The culture grows using the automated systems, while the molecular says that it's a MIC-A gene not detected in the staph aureus. So that's the clinical case. So what should be done in this case? Should we interpret, trust the identification, or wait for another 2 days? Should we or shouldn't we? So we have to answer. But we have to keep in mind, being a lab personnel, that if we are dealing the diagnosis, the mortality increases 2-fold to 5-fold if it is bacteria or candida respectively. So we have to ensure, or again we have to keep in mind whether we have to escalate or de-escalate if the patient is not critical or critical. So in this case, de-escalation was done because it was a methicillin sensitive isolate to cefazolin. Case 2, 35-year-old maid admitted with headache, photophobia, vomiting, which is a classical sign of meningitis. The day 1 of admission, all the investigations were done, and like in Mumbai for this season we do all the investigations like malaria, leptospira, because they might present with the CNS symptoms. So, but what was lacking in this particular case, there was a shortage of communication between the lab person and the clinician. So what is more important, this particular case on inquiry, he had a previous history of road traffic accident with CSF rhinorrhea, some surgical procedures were done. So if we have not elicited this history, then we would have lost this thing, because the culture was negative on day 1, all the other parameters which were suggested, like gram stain was negative, but the protein count and the sugar count was suggestive of pyogenic meningitis. Then we did the seasonal disease like malaria, leptospira, they were also negative. So the time to diagnosis was more than 3 days because the primary sample was not showing anything. So in such cases where we have to go through the pre-analytical cycle, preparation of patients, all the microbiology tests which madam has explained in her talk with the basic microbiology, the classical microbiology workup, or we have to look for some antibodies whether they are seen for some or the other pathogen, or do some molecular tests directly on the sample. So we have got newer technologies at our help after the conventional ones. And why we need this? Because signs and symptoms of certain diseases are common. I'll show you further clinical examples, and there are often mixed infections in clinical practice what we see. Mainly we have to ascertain the diagnosis of pneumonia, sepsis, and that's why the diagnostic lab becomes more important over here. And what we don't do in routine, we have all talked of basic microbiology, but we don't do anything of virology, and that's what next couple of slides are going to talk on. The virus diseases in developing countries, they are common, they are severe as we have seen in our Nipah virus experience, and they are unrecognized. Like diagnosis becomes difficult if it's a 1-year-old develops with alveolar infiltrates, a 7-year-old develops with alveolar infiltrates, sinus rate, or the diagnosis could be different. The organism which is causing, or the virus which is causing these type of illnesses in different age groups, it could be different viruses which are responsible for similar infiltrates, or it could be the same virus in the same age group which is affecting, again presenting with different symptomatology. It could be pleural effusion, it could be pericardial effusion, it could present as ground glass opacities or pneumonia, but the causative agent over is a metapneumovirus. So do we test for this? No, we don't test for this, and there's just a few examples where I have tried to enlist what all organisms can cause respiratory tract infections, and they are going to have a similar kind of picture. So how can we get rid of this? Because for viruses, it's a time consuming, labor intensive, low yield, and all those things are there, and which are confounded by like symptomatology is same for all the viruses. It needs multiple tests, or for that matter multiple PCR for as of today. So what we should be doing is like, we want better patient results in the wards, we want better infection control, better diagnosis for the ID physician, and the lab wants better diagnostic tools, and the hospital wants better money management. So this can be achieved by multiple ways. So I'll be explaining in a couple of slides. Better results, faster with having high sensitive tests, high specific sets. Yes, the lab is good, which is giving the results to the doctor, and which can be transferred into actions. And at the same time, this better result will save on the cost which is incurred in multiple tests, length of ICU stay, and the better use of antimicrobials. There are certain studies which have already shown this, that use of multiplex PCRs, it has increased the diagnosis of viral infections, or it has shown multiple viral infections in the single group. So these have been already been explained in the literature. There are multiple studies, you can go through it. It has reduced the length of stay because of use of multiplex PCR, or even it has reduced the impact on all the things, parameters like usage of antibiotic, length of stay, which is used a gene expert machine in this study, which studied impact on inpatient enteroviral PCR testing in clinical management of encephalitis or meningitis patient. So it has helped in all the manner, whatever system you use. Then it helps the physician for using antibiotics judiciously, prevent the nosocomial spread, as it has happened in the Nipah virus. The healthcare workers were infected in many of them were healthcare workers who died, and we have to look after the cost also. We have to use the antibiotics, or reduce the antibiotic use, or cut down the antibiotic use. If it's a viral infection, we cannot continue. Like for that matter, we also had seen with the H1N1 infections, where the targeted therapy for H1N1 is oseltamivir. If we know that it's H1N1, we can start the antivirals, and if it is not, and we can ascertain the bacterial diagnosis, we can go on to the antibiotics. So again, the continuation or discontinuation of antivirals and same manner antibacterials can be done with the help of a targeted diagnosis. These are furthermore examples where we can also look in for certain other bacteria like Clostridium difficile, whether to treat them or not to them. Thankfully, we don't have much problem with Clostridium difficile in Indian subcontinent, but in Western countries, and they have got lots of problem. In fact, a couple of my friends, they have done entire dissertation of their PhD on Clostridium difficile. Coming to the hospital, what is the cost which hospital bears? If it is a faster diagnostic with molecular diagnosis, it's in hours. The TAT is reduced to a couple of hours as compared to 17 hours. The cost is reduced when it comes to molecular diagnosis, and it helps in again antibiotic usage, the infection prevention, and diagnostics. So again, the laboratory is going to give you the co-infections. They are going to give quicker decisions if we are using molecular diagnostic with the help of multiplex PCR. And what it is as of available with bioMerio is the BioFire, which is going to give on GI panel. It reduces many other viral tests which is generally not done with microbiology laboratory. For encephalitis, it has got added encephalitis panels. For respiratory panels, there are much other viruses which are again detected. And the blood culture panels, it has got a single test for multiple pathogens. Again, it can reduce the workload for the complex testing of all these viruses if we use it. In the comparison with other kind of systems which are available, the traditional culture AST, many companies are marketing. The multiplex PCR, definitely with BioFire or Nanosphere, Multitop with Bruker's or BioFire, next generation sequencing like Illumina or Thermo Fisher. So all this system, what they are doing is they are detecting multiple pathogens in single sample, and there are different turnaround times for this, and the cost has been compared. So we have to choose between what we want to have and what is the time duration. So this particular system, it talks about the single system, which is an integrated system for rapid identification. There are different panels used for different symptomatology, like for respiratory it detects bacteria and 17 viruses. Just imagine, we don't even detect one virus with our routine basis. So this detects 17 viruses. The blood culture also detects yeast, while the GI panel also detects parasites, which is not generally done by other systems. And again, for that matter, encephalitis, that has got lots of viruses. Though we have rapid tests which can be done at the point of care, like antigen detection tests in the CSF sample, but this has got even virus and fungi for the diagnosis of encephalitis. It has got high throughput. I'll just, I've already highlighted the number of bacteria, virus and fungi. Result is in 1 hour. These are all FDA and CE marked with a small footprint. As we must have seen in the, I think we can skip this video which is about the biofire system. You must have visited the stall which is there for demonstration. Okay. It also helps in certain guidelines, like if there's something like virus which is going to be spread by air, we need to think about that. The government of India has already established the guidelines for isolation of the patient, which healthcare setting it is, but we don't pay attention because we don't diagnose this kind of. Now we have started paying attention with TB, drug resistant TB and XDR, but till date we have not been present. There are again many studies which talks about comparative evaluation of all the different multiplex PCR systems which are there, but the sensitivity and specificity of biofire has been much better as compared to the Verizon Luminex which is available as of now in market. And I think this slide, Shankar sir will agree, when he is working as an administrator, he have to look on the expenditures, how many quantum of antibiotic is being used, how many healthcare workers are infected and how many drug resistant bugs are being seen. So all this has got its own impact on the patient care as well as the hospital profits and the losses. So if we understand this matrix as an hospital administrator or even as a lab managers, if we understand this matrix, it's pretty where we can go for high-end molecular diagnostic and diagnose the infections at the earliest and give appropriate therapy. And this is how we keep our communication channels open. We are working with CDC Atlanta for airborne infection control at Sion Hospital. So the Harvard School interns, they do come and study the dynamics of how we handle the drug-resistant TB patients over here. And you don't want people to confuse by giving all those information. So we keep our communications channel open. Thank you very much.